Dr. Zeeshan, welcome to the podcast.
Good.
Kindly introduce yourself.
So, my name is Dr. Zeeshan. I'm working as a consultant with Sukoon Health in Gurgaon with a key area of focus in addictions, ADHD, and neuromodulation.
Nice. What a lot of people don't know that I think we have been together since nursery.
Yeah. It is likely that we have seen each other's lives from a lot of perspectives.
Yeah, let's not. We're not discussing all those right now.
Yes.
The reason मैंने तेरे को बुलाया ना कि addiction. Let's talk about it.
Absolutely.
And since this is your core compatibility वाला issue, this is where you work mostly in the core.
Mm-hmm.
Let's do a deep dive about addiction, है ना?
Yes.
When does a habit become an addiction for you?
And see, I think the term that we use is use disorder or dependence.
Okay.
And while it's always very difficult to define, one way that we look at is how it starts affecting different spheres of your life.
Mm-hmm.
We say that a habit becomes harmful before it becomes a dependence.
Right.
And when there is continued use of anything, not just an addictive substance, but even a harmful habit, whether it's gaming, gambling, when it reaches to a level where there is objective harm and we continue to do it still, that's when we say it's reached to a level of harmful use.
Mm-hmm.
When it starts impacting your social and occupational functionality, you're skipping out on work, you're not going to marriages and weddings, you're cancelling on plans with friends because you just want to sit back and indulge in your habit. That's when we say we're entering into the realms of dependence.
And you don't use the word addiction.
So addiction is a broad term that encompasses all of these things.
Mm-hmm.
And we also break it down into different steps and stages.
We'll get there. If you had to define this in one sentence, how would that be?
Well, it's doing something more than a person should, to the extent that it's now impacting not just the person but those around him.
That's really nice.
Yeah.
And why do you think that intelligent people indulge in substance abuses?
So whenever we look at the demographic profile of people who develop addictions, each person either is biologically susceptible to it.
Mm-hmm.
It could be because of their underlying personality, the way they are, because of which they've become high achievers, which makes them more likely to take higher risks and are thus more likely to risk with psychoactive substances. And then there are some people who have environmental factors, things that don't support their well-being, and they use it as a crutch to cope with those problems.
What is the biggest misconception the general public has about addiction?
I think the biggest one is you need to have willpower and you can quit it.
So willpower is not necessary to quit.
It is one of a larger plan. It's definitely one thing.
I did not know that,
Yeah.
That's good. So break it down. As a psychiatrist, how do you differentiate between habit, dependence and addiction?
So there are very clear-cut criteria,
Right.
all based on clinical evaluation and assessment, and not to take a deep dive there, but during the course of our assessment, every person who comes to us with unable to control the use of one substance or another, we try to assess in which stage are they. Are they using it harmfully or are they at a level of dependence? And based on the criteria and the diagnosis, one key factor that we also look into is there a biological component now?
Define, what do you mean by biological component?
So think of it this way, most people in college start drinking, and you usually drink when you want to have a good time with your friends or
Weekends.
as a part of celebration.
Yeah.
At that point of time, what's happening in the background is that your brain is gradually adapting itself to become more used to having alcohol.
Right.
And the next time people drink, they need 2 drinks to get the same effect. That's what we call tolerance.
Right.
From tolerance comes a point where now, slowly and gradually, your body and your brain, the chemistry is starting to look for that same hit, that quick fix that it was able to get, as opposed to, having to go to the gym, taking a walk in the park, doing certain activities. We inch towards a quick fix. At that biological level, what starts happening is that your brain is down-regulating those receptors that give the output for the alcohol. And we go from something that is a positive to something that helps us come back to normal.
Oh.
And now we're just drinking because we need to come to a functioning level, absence of drinking, and we start having discomfort and withdrawal. So people would say, I'm having bad headaches, I'm having hangovers, so maybe I'll just have a drink in the morning.
Isn't that just withdrawal happening to them at that point of time?
And it's the withdrawal that pushes them to use versus what was once a source of celebration.
Right. What are some early signs would you say that people usually ignore?
I think that's always a very difficult question to answer. But one telltale sign that always gets missed is when a person slowly and gradually starts withdrawing from their usual routine and self. Another telltale sign I would say is when you see that some person is going to work every day. They're functional, but they're working at a lesser capacity than they used to.
So we always hear this, na yaar, मैं control कर लूँगा. So is control a red flag or how do we look at it?
See, I think for every person who thinks that, that is an indication that they have insight that it's a problem that they need to fix. Now, if we've reached to a level where it's on biological level of dependence, then they find themselves stuck in a loop where they're trying to control but they can't. Because it's no longer on a cognitive level but on a biological level where the body is craving for it.
So if you are stuck in that loop, you must be needing to constantly lie to yourself to get that quick fix.
So there's different cognitions to it.
Right.
Some people will rationalize that because I'm having 30 problems around me, that's why I need to get that quick fix.
In a larger scenario, we'll do उसमें अच्छे से बात करते हैं. Where do families go wrong when they see these early signs? एक चीज़ करना चाहिए versus they do the other thing and the addiction becomes even worse.
See, I feel I wouldn't say families do anything wrong because every person does and takes every action with best interest in mind. Families play a huge and crucial role when we come to that discussion later. But I feel what families can do differently is to seek out help as early as possible. Especially when we talk about whether it's psychoactive substance use, behavioral addictions, the earlier we intervene, the better the outcomes. So I would say families should feel more empowered and encouraged to seek out help. Most of the times, the first contact that we do is always with the family, where we sit down with them, we try to understand the situation. And I think if more families are open to the fact that we need to seek out help, we need to talk to a psychiatrist, that will definitely change a lot of things.
सही है. अभी भाई let's talk कि what happens inside the brain when in an addict's brain? What is happening अंदर at a chemical level? Let's talk about that.
So while all addictions have different targets, there's one common circuit that we've seen, which is the Hail Mary, which is the reward circuit, also known as the mesolimbic circuit. That's the circuit which also signals through dopamine, which is why you'll get to hear, I need a dopamine detox or I'm dopamine hooked. That's the dopamine that we're talking about. It's the one circuit that controls whether we approach or retract from anything. So, for example, you call me up, hey Zeeshan, let's have some lunch today. My circuit is releasing a short burst of dopamine that tells me, yes, it's going to be fun because I'm going to meet my friend and we're going to have lunch. And that motivates me to come out of my comfort zone, get ready and come to see you.
Right.
In addictions, now that dopamine is much, much stronger. And when we talk on a biological level, the brain is seeking a hit so quickly that shorter pleasurable activities like going to the park, playing a game, that doesn't cut it. And we are more likely to get quote-unquote hijacked into seeking dopamine through the substance itself.
पर यार what I remember studying about dopamine is कि it is a pleasure kind of a chemical. It gives you a good feeling. Like you've done something good, you've achieved something, you'll have a burst of dopamine. इसका craving में किधर चला गया? Is it the extremeness of the...
Okay, let me, since you asked that, that's a good question.
Yeah.
Imagine if you and I are biologically neutral with 100 units of dopamine. Okay? We feel pleasured or happy when that 100 becomes 110. Right? So each time you're seeking an activity, it's to take that 100 to a 110. But
the baseline increases.
So imagine 5 years down the line,
right,
our dopamine stores are down to 50. Now we are not seeking dopamine to feel pleasure but to feel normal. And if we don't, we now start having all of the discomfort, all of the phenomena, what we call as the withdrawal, whether you call it cravings. Each are very different in their own technical sense, but for the sake of this discussion, we are trying to cover up for something that is lost due to repeated overuse and misuse of a circuit and system.
Oh, I was thinking about it the other way around. You आपने baseline बढ़ा दिया. So, but you're saying the stores are getting depleted in a way.
Yeah. So, and all of this is obviously an oversimplification of a very complex circuit. But largely, think of it this way, we are now using the dopamine just to come back to what it feels to be ourselves.
And why do you think addicts में बहुत बार relapse हो जाता है? You know, you quit something and then they survive without the quick fix for a few days and they quickly relapse. So what is happening inside the brain at that point of time? Same thing जो तूने बोला?
Well, I think you're asking all of the right questions which each go into a very specific technical domain. To put it very simply, see, the first and foremost is we always say it is a substance use disorder. It's a biological condition like any other condition, like hypertension, diabetes. So I always tell families and individuals going through the process, try to imagine the substance or whatever problem we're talking about as diabetes. So if somebody who's diabetic, do you sit down and tell them why your sugar is rising?
Yeah.
And then you say, go to the doctor.
Right.
What you don't tell them is, you're not trying hard enough, you're not hitting the gym. Why aren't you cutting down on your food? And sometimes you're trying all of those things.
Right.
And yet the sugars are going up because there's an underlying biological problem. In addictions, we also look at it as what we call as a chronic relapsing and remitting condition. Individuals who go through the best addiction programs are still at a higher risk of developing a relapse because while we cover for the deficit, we may never come back to a pre-addiction exposure phase.
Okay.
So one thing that we've learned, the best treatment for addictions is prevention.
So let me get this straight. You have a patient who has a substance abuse problem. You have worked on that person and eventually that person has managed to quit with the substance, with whatever you have done, therapy or medication or whatever, we'll get to that. But his life later on will never be the same as it was before the drug happened to him in his life.
And I think that's definitely one of the unfortunate realities we have to start with. That being said, when we approach the cases clinically, we also have to look at whether the addiction is a part of an underlying problem. Is somebody having an underlying condition such as ADHD, an underlying mood disorder which they're trying to mask and cover, or maladaptively cope through addictive substances? We also look at the environmental factors, whether they are playing a role, and then addressing those, as well as looking at what is the severity of the addictions. Depending on an individual patient's profile, we are able to then project what is the likelihood of a positive or a negative outcome. But in a very large general populace sense, I would say if we're talking about somebody who has met the criteria for use disorder and dependence, there is always going to be a percentage risk of relapse. There is always going to be a percentage risk of reoccurrence on re-exposure. And a lot of guidance and handholding needs to happen, not just during the treatment in an addiction unit, but for the subsequent few years. And that's what we call as our aftercare plan. So any person who comes to us, our job does not end when we say now you're discharged. Our job ends 6 years, 10 years down the line, where we say now we've hit all of these landmarks. And at each step, we have a different approach. And more often than not, medicines are usually 5 to 10% of the overall intervention.
It's mostly the discipline that you are able to inculcate in that individual, probably.
Let me put it this way, it needs a team of 6. A psychiatrist, a clinical psychologist, a social worker, physiotherapist, dietitian, and occupational therapist. It's when all work in conjunction is when we say that we are able to attract and target every sphere of dysfunction and work towards a healthier recovery.
ये बता भाई कि when craving starts for somebody, a lot of people are able to control that craving, at a point of time the logic just shatters apart and you need the substance, whatever you need to. What is that boundary that gets crossed when the logic just fails?
Well, I think, it's very individual specific again.
Okay.
The example that I use is what I call as the airport phenomena or the airplane phenomena. For somebody who's smoking a pack a day, as soon as he boards a long-haul flight from Delhi to New York, he's sitting there for 17-20 hours, he's not smoking. He's not sensing his cravings. And would you say that he's cured in the aircraft?
I would say he would know that it's impossible to smoke here. So, I mean, that's what I think.
And at the same time, once that cognitive realization happens, his discomfort with the cravings automatically regulates.
Right.
But the first thing he'll do after he crosses through immigration is find where the smoking booth is.
Yeah, before coming out of the airport, he'll find the smoking lounge, he'll have a quick smoke and then he'll come out, right?
Pretty much.
Right.
So, the boundaries at which an individual would say that now cravings are unmanageable is definitely person to person variable. But from a disorder perspective, we would say when the cravings or the use starts to take priority over everything else, there would be individuals who will refuse to travel to certain countries because they say, I can't spend 10 hours without smoking.
Right.
We would have people who would scramble through that, okay, I'm going to travel to that country. So I'm going to talk to these 10 people. I'm going to make sure there's my fix ready when I land. And oftentimes their whole life now centers
around
effectively.
the fix.
And
Right.
that's what we call as the brain getting hijacked.
Yeah, that's what I wanted to... I was reading about this, the hijacked brain system. So this is exactly what I think you're talking about.
Pretty much.
है ना? Abhi, let's move on to cortisol. Why is it so important in addiction?
So,
Cortisol is a stress. So I think stress cope up करने के लिए dopamine fix चाहिए and so having a fix. Is it correct or is it much more complex than I am making it to be?
And I think, when we talk about neurotransmitters, I would say we have to look at what's at the core and the center. That's your dopamine. The second layer on top is your opiates, the pain versus pleasure dichotomy. And we now have to look at the output. And the output of distress and discomfort, one of the ways it's communicated is through cortisol. It becomes important to talk about cortisol during addictions because that becomes a target for us for peripheral symptom management. But for understanding addictions, I would say building an insight into how dopamine works, that is the more important area to work on and focus.
So, why does very simple? Well, let's just पहले बता कि why does stress increase cortisol levels?
Well, it's definitely the signal through which our brain communicates to the body that we're under stress. And it's pretty much the same way as it's the chosen one.
Yeah, भूख लगना है तो kind of thing. So, when your cortisol level rise, why are addicts trying to find their fix?
So let's talk about hijack, okay? We start again at the center. We're already dopamine depleted.
Right.
That dopamine depleted individual is now feeling a sense of discomfort. That is getting communicated to the body through the cortisol. The mind and the body is not tuned enough to say that this discomfort is because of an addiction or it's because of some physiological issues or something else. All it knows is I am sensing discomfort. And the only thing that can comfort me is the variable that has now hijacked your brain.
I have seen this with smoking with a few of our common friends. One of him had quit smoking and he was going through it very disciplined manner. He was supposed to get married, but it didn't happen. That was a very stressful thing for him. So he's like, "Bhai, chal jaldi cigarette peene chalte." After 2-3 years of being clean, he wanted that thing. So the question I think I'm trying to ask is, why do people relapse in a stressful environment? Probably.
As I said, that it is, when we talk about sobriety and treatment, it is a lifelong process. It's about preparing for the known, preparing for the unknown, and having some level of insight and support when things get stressful. Despite all of that preparation, as you said, there are certain life events which will supersede what should be normally expected with any person. As you said, for somebody to have planned for getting married, to be motivated, and to have that event taken away, it is a significant life stressor. I can only imagine the level of distress they're going through. In situations like these, this is where all of the prior cognitions, the person may have very well tied the discipline to a marital outcome. We never know. That could be one of the reasons why.
Right. A lot of people during जब stress होता है, they consume alcohol and then the stress levels fall. But does it raise the cortisol levels later, alcohol?
Absolutely. See, always think of our brain as whatever helps today is going to create the same problem tomorrow. As it helps today in helping you quote unquote manage stress, what it's also doing, if we talk about just alcohol as an example, it's disturbing your sleep architecture. Why do you need a good sleep architecture? Because when you sleep for good 8 hours and get ample amount of deep sleep, that helps your brain regulate cortisol better, which means your outflow is more smooth and systematic. Because your sleep is disturbed, your cortisol regulation is poor, which means there are higher likelihood of cortisol spikes happening, which means there are higher likelihood of you now seeking out coping to deal with that cortisol spike.
Hang on. I have a patient, 45, no systemic illnesses. He plays tennis and he's very fit. He goes to the gym. So it's all blood levels are all good. But he has a habit of having 2 to 3 drinks every day before going off to sleep. He works in a very high stress. His job is a very highly stressful job. He said, "Doctor साहब मेरे को नींद ही नहीं आती." To induce sleep, I have to have 2 to 3 drinks. And I know through bad experiences that alcohol-induced sleep is not a very good and peaceful sleep the next day. Then how do these people function later on?
Well, I would say the individual that you're describing is showing no signs of physical ailment. Is showing acceptable levels of functionality from the metrics you're describing, and is able to live up to his individual goals and responsibilities. And with the regular and controlled use of alcohol, what he's not reporting is any disturbance that he can perceive. Whether it's the quality, the duration, or the amount of rest that he's received. So I would say this is where we come to ask the question that, is this dependence, where he's neglecting his physical health, where he's continuing despite harm? I would say no. This gentleman here is able to regulate his intake. He's not reporting any kind of discomfort and is able to do his duties and responsibilities with a controlled use of a substance that is otherwise addictive in nature. So if anything, we can very well look at this as a maladaptive way to cope with poor sleep. And the challenge here would be, how can you certify and offer an alternative that is better? And if you're not able to do that, the individual is less likely to engage with you.
So, ऐसे लोगों को we would give suggesting melatonin, a little bit of alprazolam. Does that help?
Well, the first question to ask is, why is this person in the doctor's clinic?
No, he had come for a refraction. I was just starting, it's a habit to start taking history. So, found this out. It had nothing to do with my way of treating what I wanted to treat with him. I let it pass. If everything is fine, जाने दे भाई. I wouldn't stress about it. But you were talking about it, that's why I brought it up a bit.
So I would say this is a good opportunity for engaging any patient, and it's not necessary that these should happen only in a psychiatric clinic. This is something that should be common across the board. The moment a person is in a doctor's clinic, they are more receptive to understand medical guidance.
Right.
It is also an opportunity for us to talk about brief intervention before we talk about medications. It's to understand what purpose it is serving for them. Have they tried any alternatives? Have they understood what are the short-term and the long-term negative consequences of consumption? Have they ever considered getting a more thorough scanning done, whether it's an elastogen scan, oftentimes called a fibroscan, to see whether there is an impact to the liver that is not obvious or evident in the LFTs.
मैंने उनको वही बोला था, your LFT will always be normal until वो 50% damage के बाद ही आपकी your LFT will start deteriorating. You need to do fibroscan to figure out if your liver is damaged, getting damaged or not. Let's see. ठीक है. Why do people cigarette पी के अच्छा लगता है, but when we know that nicotine increases stress hormones later on, वो क्या, what is happening inside the body?
See, think of it this way. Nicotine in itself has a very short half-life. And because the half-life is shorter, that's when the rebound of the withdrawal kicks in. And until it becomes a closed loop.
Right.
Where we're stressed, we smoke, then we function, and then we keep functioning until we feel stressed.
Right.
And with nicotine, because there is no obvious cognitive impairment, as happens with alcohol, cannabis, or the other substances, you will see nicotine being used more frequently and regularly.
Right. Abhi, what are some India-specific addictions that तू ही बता भाई, what do you see on a most common basis?
See, I would say I've had the opportunity to work across multiple settings, whether it's a primary health center, a tertiary general hospital, tertiary psychiatric unit, and a privately run unit. And what we see is each person that presents, the substance of use will be different based on what is readily available and accessible to their location and situations. So if I talk about somebody who's staying in the periphery, in a village or a rural setting, I see more common use of locally procured and manufactured alcohol and tobacco. At tertiary hospital levels or general hospital, we see more frequent referrals coming across from other specialities. So a gastroenterologist who's made a referral to us for alcohol-related liver disease changes and now requiring further management. So we will usually see people reaching at a very critical stage.
It's mostly alcohol and nicotine.
And as we move to private addiction psychiatry units or privately run independent psych units, that's where we see that cocaine, MDMA are extremely rampant in the country. Cannabis is something that goes under the radar because its dysfunction doesn't become obvious until
much
it's already
later.
late. And whether it's induced psychosis, whether it's induced amotivation, that's something we get to see more within the psychiatry specialty units.
But see, you born and brought up in Nagpur, working in Delhi, Gurgaon. Idhar and udhar, the substance remains the same?
I would say, you get really, really good poha in Nagpur for $20. That poha in Delhi is $100.
Okay. Nice way of putting it. Is weekend drinking truly safe? Because nowadays, I was just reading a report that the Gen Z people are drinking very, very less. When alcohol industry sales have come down by almost 24%. So I think the younger generation is not drinking as much as the millennial generation drank. But
and
still,
I think collectively mental health services are doing something right then. But I would say with recent advances in neuroliterature, even one single drink is enough to increase the risk of hepatocellular carcinoma.
I mean, I think we have read that 160 ml a day
So
this is what we read. I think.
And I remember it was there in our textbooks that a glass
I know.
of wine or certain units of alcohol is good for cardiac health. We have
Drank
since,
over a period of 60 minutes is very good for cardiac health. And now suddenly the literature says even a drop of alcohol is injurious. Okay.
Now, my analogy in all of these situations is very straightforward. We must understand two very fundamental facts. Each person has a genetic susceptibility of developing an addiction. We will only learn of that once an individual is exposed.
Right.
So there's no way of predicting who is at risk of addiction until they're exposed to the substance. The second aspect is we start interventions only when the person becomes dysfunctional and has already lost a major chunk of their life.
Right.
We look at a person who's coughing too much, he's not able to get out of bed. That person hasn't been able to function at 100% for the past 5 years. For somebody who's day drinking today, has not been to his potential in the past 10 years and could have been in a much more optimum functioning had he not had that exposure.
Right, true.
So from a guidance perspective, we would say anything that we know comes at a risk of derailing you from your maximum potential. Avoidance is the right course of action.
In terms of number of individuals having alcohol versus number of individuals having smoking, with a caveat that there is no overlap happening, I think the number of people consuming nicotine would be higher than the number of people having alcohol, because it's much more readily available and you can smoke publicly and it's not as much of a taboo as drinking in public, I would say, right?
You know, it's really going to tickle your brain.
Arey yaar.
When does society collectively start to change around substances?
Okay.
So we have seen that nicotine comes with a much higher potential of developing dependence compared to all of the other substances.
Right.
Given that propensity, it has now become socially or culturally acceptable. It is more readily available.
Yeah.
And multiple efforts to thwart its availability have not yielded outcomes.
Right.
And for that reason, that is one of the factors we would look at and say that there is a much higher population burden of nicotine use disorder than for alcohol or any of the other substances.
I think when 60s or 50s, airplanes maybe people used to smoke pehle. It was socially acceptable then.
Yeah.
And then the taboo phase came and now again, I think it's gone now. Pata nahi, let's see. Screen addiction, bhai, let's talk about it.
Yeah.
Batao.
So another thing that's really come up in the past few years is behavioral addictions. Behavioral addictions earlier was a very small diagnostic set that would include gambling disorder and a few other pathological behaviors. Of now, with ICD-11 and the neurodiagnostic criteria, gaming disorder is in itself a new diagnosis. Yes, with subspecifiers of predominantly online versus offline gaming.
Oh my God.
And I would say when you have to think about any behavioral addictions or substance-based addictions, what we want to look at is the level of dysfunction. So, and this is where it becomes very tricky. Now, a professional esports player is sitting in front of a screen 14 hours a day.
Right.
We don't say he's addicted because it is his source of social and occupational gains. But for a child who's preparing for a competitive exam, for him to say that, okay, I'm just going to play for a while, and then they spend 14 hours playing where they're not studying. And the bottom line is we have to always look at whether a particular habit takes priority over something else to the extent that it is significantly hampering their social and occupational well-being and functioning.
पर मैं तो ये भी पढ़ रहा था ना बीच में कि scrolling through reels indefinitely, that is another way of giving yourself dopamine hits again and again and again. Eventually you land up with something called as a brain rot. Everybody's talking about nowadays, I guess. What do you have to say on that?
Well, honestly, I am still learning.
Okay.
But what I can say is dopamine is not necessarily bad for you. Seeking out dopamine is always, that is how we have survived.
Right.
That is part of our evolutionary process. It is important for an individual to have some level of insight where they start to think that, hey, I think I have a habit, it's definitely not working in the right direction for me, and maybe I should do something about it.
Let's talk about some hidden drivers of addiction. Is it a masking mechanism for anxiety or depression? Is it used?
Could be. I would say it's maladaptive coping.
Okay.
And we say that, there's a very famous, or I would say there's a saying, men drink and women eat.
Oh, correct.
So
I don't think it's correct anymore.
But
Yeah,
in a
by
larger
and
sense,
by and large, yes.
what that is implying that whenever we're feeling low, we each seek out different ways of coping and finding a way to reverse it.
Nice. ADHD, you work a lot with ADHD, right? ADHD and addiction, क्या relation है भैया?
So think of it this way. Another thing that we started learning of late is, our earlier understanding was ADHD is a childhood disorder that completely...
Adult ADHD as well.
And when that childhood disorder continues into adulthood, that's when we say it's adult ADHD. It's not something you get after you become an adult, it's always been there.
So are the parameters of diagnosing a childhood ADHD versus adult ADHD different or the same?
Pretty much the same.
Okay.
It's only in which time frame that you're looking at that you would categorize one or the other. When we talk about ADHD, its core biological pathology is the deficit of dopamine.
Oh.
But in a different organic circuit. And if you see, most of the medications that manage ADHD are one way or another trying to target dopamine, but in those selective circuits. Second thing, an individual with ADHD, the hyperactivity part will have something known as increase in impulsivity. And an individual who's more impulsive is more likely to seek out quick gratification. And when exposed to psychoactive substances, are more likely to use it to regulate the dopamine, not just in one, but the pathological circuit.
Medical marijuana, it's not used in India, वैसे भी. Will it cure an ADHD guy?
See, I think when we talk about marijuana as a cure, marijuana or cannabis is produced by our brain. It's called anandamide.
Yeah.
So our brain makes its own cannabis. Its half-life is in nanoseconds or milliseconds, I don't remember exactly. But exogenous cannabis acts on those receptors for 4 to 8 hours. The challenge is, if it helps, we're not sure how it does.
We've seen people with Alzheimer's and different neurological functions improve with medical marijuana. काफी लोगों seizures improve होते हैं.
But we don't know why.
We don't know, exactly, yeah.
And not every person who has Alzheimer's who takes cannabis gets better.
I'm not saying it's a blanket thing, but there have been the reported cases of them. So would you think in a bacha with an ADHD or an adult with an ADHD, certain controlled form of medical marijuana would set that dopamine receptor correct? I mean, I don't know, I'm just blabbering.
I know. I would say, see, as clinicians, the one thing that we always have to put in our decision making is risk versus benefit. So the question that you're asking for any novel intervention, I would reflect back and say, what is the risk and what is the benefit? What is the risk that this child will develop a motivation with medical marijuana or marijuana as a whole? What is the risk that this child does not meet his full potential? Versus, what is the readily available option that is clinically validated and is proven for a fact that this is going to help him?
Nice.
I would choose those options first.
Abhi, just a quick thing on what is high functioning addiction and why is it dangerous?
Again, I think this is more part of pop psychology than anything else. But as I told you, one of the key pointers for us to draw and say that this is now becoming a use disorder is the decline in functioning.
Right.
For an individual who's able to remain functional while continued use of the substance, they are at a point or they are at a risk where they get diagnosed late they are at a risk where they usually come into us with physical comorbidities. To put it in simple examples, I've worked with a lot of patients who come from very high net worth families. They don't have to worry about income, they don't have to worry about socializing or social expectations. So in these individuals, they are quote unquote high functioning because their functioning is in itself a very broad parameter. And oftentimes interventions come in where either they are repeatedly found offenders, getting into the crosshair with the law, or they're now developing a physical ailment that requires management of the addiction.
What happens at withdrawal when you hit withdrawal? Somebody is through treatment, and what in general happens during withdrawal and detox?
So whenever we talk about inpatient management of addictions, the first thing we have to look at is, does this addiction require hospital-based care or can we manage in the community? Community care is always the first priority. If we feel that there are variables that put us at risk, hospital-based care is the only option. On day one, we formulate what our next treatment goals are for the next 1 month, 3 months, 6 months. The first phase of treatment is what we call as the acute phase or the detox phase. This is where we will use medical substitutes to gradually compensate for whatever deficits the addiction has caused and to bring it down in a controlled fashion to make sure that there are no life-threatening or disabling consequences.
Right. Do you see withdrawals ke time pe some red flags that, you're managing somebody conservatively, and some red flags that families should be aware of, ki ye dikha, so you should immediately get back to the doctor?
Yeah. So we call those as early warning signs.
Right.
And we always have guidance documents for the person and the family. These talk about a lot of things, including the early warning signs that they need to watch out for, specific to each addiction. As for hospital-based care, we have a team of trained psychiatric nurses. We have a team of trained helper staff, as well as clinicians who are always on the watch and look out for any kind of change that points towards something serious.
Alcohol-specific withdrawals, how does it look over time?
See, the key point is the first week after somebody's who is on a biological dependence level of alcohol, the first week is most critical. We run the risk of delirium tremens, Wernicke-Korsakoff, withdrawal seizures, and a few other conditions. So it is in that period where we need very strict medical supervision and observation. We do what is known as withdrawal assisted medication plan.
वो alcohol dehydrogenase वाला कुछ तो भी देते हैं ना?
That's for much later, I think, what we're talking about. But in the acute phase, depending on the level of withdrawals they're having, whether it's the CYA or equivalent scales are applied, and we decide the dosage of medicines to make sure that we have ample coverage.
Let's say somebody comes to you, say, doctor, I'm addicted to alcohol and help me quit. What is the timeline you draw for that person? Honestly, after an initial assessment, let's say.
I would say that timeline can range anything between a month to 10 years.
Really?
It boils down
the
to...
The degree of dependence ke upar hoga na?
There will be so many factors and variables. And think of it this way, the first time that they're coming in, they haven't even thought about the 10 things they should have told their doctors. And I will make sure that I cover my bases, but in the follow-up visit, I'm going to get more insights. Right. And then in the third visit, another insight. But I would say each person has a different timeline, and we do our best to make sure that we cover our bases and personalize it to the person.
Is home detox safe, unsafe? How do you term it?
Well, depends on the level of severity of the condition. As I told you, what you're talking about home, we call that as community-based management.
Okay.
And it is our job in the first assessment to start guidance on whether we can manage in the community or we require hospital-based care.
I would say once you have an addiction and you want help, I think the first step is acceptance that I have a problem and I need help is what I'm thinking, or am I wrong? So what if a person who's watching this and he's thinking about quitting whatever type of addiction he or she has, what should be the initial first steps they should start taking?
See, I would say it's most important for them to feel comfortable seeking out help.
Mm.
For any person at this point of time, if they're thinking, I think I have a problem,
Mm.
it's important to just talk to a professional to understand to what extent, to what severity, and what can be done.
Mm.
More often than not, you may realize it's something you can manage on your own.
Okay.
So, the most important thing for any person who's asking themselves this question, talk to a professional.
Mm.
And
But so sorry, but usually what we see is motivation alone in itself doesn't help break an addiction.
Mhm.
I mean, motivation dies after 2 to 3 days. ज़्यादा से ज़्यादा 5 days. उसके ऊपर motivation नहीं रहता है.
Mhm.
So what else should they try to inculcate in their lives while doing a detox or completely quitting?
And I would say again, it becomes so difficult. But to give you a similar analogy, if I ask you, a patient who's having difficulty and blurring of vision, but they're not willing to go to the ophthalmologist.
Mm.
Every person is going to tell them, why don't you just wear glasses? Go to the optometrist.
Yeah, one fine day he'll land up in my opinion. I know. Oh.
And oftentimes you would feel, if only I had seen this person 6 months ago,
Right.
I could have done something differently and helped him better.
Obviously. तो that's on a routine basis वो तो लगता रहता है.
And this becomes far more important when we talk about addictions. That if only we could have reached out sooner, we could have done so much more.
Mm.
And the second thing is, each, like refractive errors, have multiple underlying pathologies. With each addiction on the surface, there are underlying pathologies that get missed.
Give me an example.
Somebody who has undiagnosed ADHD, somebody who's going through depression, somebody who's having significant interpersonal conflicts with their marital partner, or the marital unit is dysfunctional. The parental-child unit is dysfunctional, because of which now addictions become a crutch. These are all on surface going to be presented as somebody who's having difficulty regulating A, B, or C.
So, emotional parameters also play a role in addiction.
We always look at it in what is known as the biopsychosocial model.
Okay, right.
So the transmitters, biological, an individual's personality and thought, that's the psychological. Everything outside and around them, that's the environment.
Then when does therapy come into play?
Day one.
Day one.
I would say medications are 10%, maybe 20% when we talk about addiction management. A huge chunk and role comes in therapy, in family work, in occupational therapy intervention. So as psychiatrists, we not only look at prescribing, but look at case management, how to delegate across the team, how to take feedback from the team and learn from them. And that's pretty much how management of each case moves forward.
At what step do you, in your treatment or community rehabilitation of a patient, you decide कि भाई अभी नहीं, I have to send this or refer this patient to a rehabilitation center? What are those parameters you're looking at?
Mm-hmm. So I think if I understand the question correctly, for practicing clinicians, what is the point where they should think about referring to rehabilitation services?
Mostly I've seen alcoholics बहुत ज़्यादा भेजे जाते हैं.
So again, because the criteria is very specific and requires clinical evaluation by...
There has to be some parameters na कि this is the threshold and hence this patient now needs a rehab, and community work is not going to help him, and therapy is not going to help him, medication is not going to help him.
So given that not every clinician may have the bandwidth in that patient interaction to look at underlying psychiatric comorbidities, to look at community dysfunction,
right,
and to look at severity of dependence. A mere quantum of substance consumption may not be adequate to conceptualize a case. And we always recommend referring clinicians that we are happy to get on a call to do a brief assessment and understand whether we want to go with community-based care or hospital-based care.
Right.
And the second thing we always recommend is for community clinicians to always make the referral to psychiatry services where we can do a systematic triage. And for clinicians who do want to do this independently, American Society of Addiction Medicine has a very good classification tool. So it's ASAM for short. You can get it on the website, and it'll help clinicians classify in real time with all of the relevant questions they need to ask before deciding whether we want to do a community management or a hospital-based management.
Exactly, that is what I was coming to. There has to be something, a structured thing.
Let's just say very time-consuming, but for those who are interested, that's the tool I would recommend.
Give me a link and I'll put it over here. I mean, I'm sure a lot of people must be using it already. जिनको नहीं पता, we'll just post it over here.
Pretty much.
Then we also know, बहुत बार यार, we see patients who go into rehab, but they relapse even after that. What is happening at that point of time?
See, what's happening is one way or the other, the deficit is there. And whatever interventions have been tried, at that point of time, something either unexpected has happened or we're looking at some new variables which were not factored in the first time. To put it very simply, it is a high likelihood that a relapse will happen. With addiction interventions, our goal is to decrease the probability of a relapse.
Right.
And another thing to understand is there is a difference between a lapse and a relapse. Relapse means
define
when you go back to the earlier pattern of use. That's when we say a person has relapsed. But for somebody who hasn't had alcohol for 2 years, has one drink, that's what we say is a lapse.
As long as he doesn't have a drink afterwards, he's fine. That's a lapse.
Now what happens is a lapse
can lead to relapse
if nothing is done about it.
Right.
And that is where early intervention, community-based engagement, and regular social worker follow-ups become very important to prevent a lapse from turning into a relapse. And that's when I say we don't talk about addiction management as something we do for, in the hospital.
Yeah,
it's a 5-year, 6-year, it's a
yeah.
10-year process.
So let's say somebody who's really trying good और एक बार गलती से lapse हो गया. What should he or she do next? Should they call the doctor, the sponsors, somebody they trust?
Whoever is the point of contact that is decided,
right,
they should definitely reach out to them. They should not feel guilt or shame that it happened. It's important to reach out so that somebody who's there, who's looking out for you, are able to help you and keep it from getting worse.
What would be that conversation like? Just, hey, I've just had a drink and I don't know what to do. I'm feeling bad about it.
Now, depending if it's a sponsor, the sponsor will have their guidance, they'll come, they'll intervene, they'll probably introduce some new measures that can help prevent that lapse from proceeding further. If it's a social worker, the social worker will make sure that they're connected back to the treating clinicians and they can talk about immediate therapy work, certain medicines that can help prevent the relapse from happening. And those are the situations that we commonly encounter.
Role of families in addiction. Dysfunctional families may use addiction a lot as a way to cope up with it's a coping mechanism. बहुत बार. How should families deal with this?
I would say a good outcome when we talk about addiction management depends on how much the family is there for the person. The best outcomes are one where individuals have good support. So one study that we had seen, individuals who are unmarried are more likely to develop addictions and have poorer outcomes.
Come again.
Married people have better outcomes.
Really?
Yes.
यार फिर तो हम तो कितनी बार सुनते हैं.
And this in itself will become something that raises a lot of eyebrows.
Yeah, I mean, sorry, but I have often heard, and very recently I've come to realize one thing that I used to believe till now, that husband comes home from work, he gets drunk and he beats the wife. This used to happen in the lower socio-economic strata of the society. It has been recently brought to my notice, this is not true. It happens in all stratas of society. This is not,
and across genders.
Yeah, so and you're telling me that there is better relapses is more in married men.
Better outcomes when we talk about...
not relapses, outcomes. Okay.
More positive outcomes when we talk about marriage, and we look at marriage as a very strong protective and supporting factor.
Okay.
See, this often comes up in discussions with me and I tell everyone the same thing. We retain things that raise an emotional response in us. We know about those 5 cases where the husband is intoxicated and beating the wife. There's 995 men who are not doing that.
Right.
But we're not interested in hearing about a man who comes home, quietly has a drink, eats dal chawal and goes to sleep.
Yeah.
And it's important to understand that the 995 are doing much better because
Obviously.
there is A, B and C supports in place. The parental unit and their support is important, and if we see that there is family dysfunction, because addiction does not impact the person, it impacts the family. As in your example, the husband is the one who is biologically, psychologically addicted to alcohol. His wife is still getting to feel the physical discomfort. She's more at risk of developing anxiety and depression. She's more likely to have more long-term negative outcomes for herself.
Right.
So it's a disorder that's impacting the family, and that is why working with family and their role becomes so important. But they are crucial and critical to positive outcomes.
How should families respond when somebody relapses? I mean, obviously, I'm thinking panic mode mein jana is the worst thing they can do at that point of time.
I would say this is something that we take months to go over and just coach every family member.
Right.
The most important thing for families to do at this point of time is A, to not get into a conflict or confrontation at that time. B, to always talk about their own emotions, how they're feeling and how it's impacting them. We oftentimes go into a discussion that becomes more combative and does not yield outcomes. And more importantly, for families to try and understand how they can seek out immediate help. They should always know these are not situations that you should manage on your own.
I just recalled another case. One of my friends, driver, chauffeur, had a drinking problem. He came to me because he couldn't see properly. He sent it to my Baba ja dekha de karke. He had optic neuritis because of alcohol-induced toxicity led to his optic neuritis, and hence his vision went down. I said, I'm sorry, there's nothing much to do. I can only give you certain drops to help you make sure that at least jitna hai utna rahega. I can't increase your vision at this moment. If you keep drinking alcohol, you are going to lose your sight. He eventually lost sight in one of his eyes. He went to a withdrawal center, went to GMC probably, सब किया, medication किया, but he did not have medication because he knew कि मैं दवाई खाऊंगा तो I'm going to puke out in a while. So he stopped medication, बंद कर दिया. He started having alcohol again on a daily basis. One day I went to this friend's house. We had a dinner. I saw the driver, feet swollen. मैं बोला, bro, your kidneys are shutting down. ऐसा non-pitting edema, pura swollen, everything.
So he's ARDD in its terminal stages.
He died. Why couldn't he control himself? What was happening there? उसको मतलब I couldn't figure out. He was just 35 years old, यार. क्या? What went wrong?
As I said, I think what we've discussed over the conversation, all I can say is we have to look at the person's biology, the psychology. And I wish I could have that one punch answer for you.
I know.
But I want to impress upon you as well that there's always more than meets the eye.
Obviously.
And what is most important is if only we were able to do more for him and have some more meaningful contact.
Okay, I'll ask you some quick questions and give me some quick answers. Someone who drinks on weekends but can't stop at 2 drinks, what should he or she do?
So this is known as an epsilon binge drinking pattern. If they feel that there is a problem, that they should definitely seek out therapy. Therapy works wonderfully well for such individuals.
A smoker says, my smoking helps reduce stress. How do you respond clinically to this situation?
Help me understand what other ways you would cope with stress before you start smoking.
Right. A doctor binge drinks after a very heavy work day. How do you tell them? He knows everything.
I want to understand what brought him to my table.
Oh, nice. A spouse had to quit drinking, but the other spouse keeps on drinking and hence can't quit.
I think this is a marital unit issue. And we have to look at the both together and see how we can move past the problem.
अच्छा अभी ये तो we discussed first कि even a drop of alcohol is not good for you anymore. How do you handle travel, weddings, functions?
Are you asking me or like?
Yeah, I'm thinking भाई तो मतलब an ideal world is I don't think it happens कभी.
Oh, you should definitely try the Meta Quest.
This is fun. What changes by one month of recovery? What changes at 6 months of recovery? What changes do you see at 1 year of recovery?
I would say first the biology reverses,
Right.
then the psychology, and then the social part. I'll keep it very simple. 1 month in, you're feeling more energetic, you're more active. You start feeling like how you were back in the days. 6 months in, you are in control. You feel more productive. You are back in the flow and you are loving it.
Right.
1 year down the line, all of the relationships that you once saw as strained are now seemingly the most polite and pleasant part of your life. Your spouses are happier, your parents are happier, your friends are looking at you and they are thinking, wow, we don't know what happened, but in the last 1 year, this guy's pulled a 360.
Right.
And I would say that's the expectation to keep in mind.
What happens to the brain when the healing process happens?
Whatever is down-regulated starts coming back to a baseline level again.
And what habits would you advise someone for long-term sobriety?
Exercise, exercise, exercise.
Why so? How does it help? Batana.
In 1,000 ways, that would require 6 different podcasts. To put it simply, it will make sure it's a healthy and effective habit.
Yeah.
It reverses not only the chemistry in the brain, but helps combat some of the oxidative stress that the body has gone through. It will help you build structure, routine. It's something that is very effective for ADHD management, for management of depression, anxiety. So it is at the helm of management of a lot of psychological distress.
What is one hard truth every addicted person needs to hear?
So I would say the correct term again would be an individual with
substance dependence.
disorder.
Yes.
And yeah, the one hard truth that every person needs to hear. It's not about you. The problem is an illness in itself. Second, there are no variables that there are some variables you control, not all of them.
Right.
And by not reaching out for help, you are only complicating and making the situation worse.
Is there, if somebody is watching this and he or she wants any kind of help, what should they do?
Reach out to your nearest mental health professional. Period.
Are there some helplines or where people can reach, make a phone call?
I would say there's a lot of resources. I don't know off the top of my head, but I'll definitely share those links with you. But I think a simple Google of clinical psychologist, psychiatrist is a step where you can understand how the closest help is available. You can do sessions online. That's a good point to start.
People are taking therapy via AI bots
And
LLMs. This is the most bizarre thing I'm listening to nowadays.
I would say, everything in that sphere is evolving, and it's too early for us to look at it one way or the other.
True, but I think people should not be seeking out a ChatGPT agent for therapy. Why can't you go to a clinician is what I'm trying to understand.
I think, there are a lot of barriers there, whether it's a financial barrier where therapy is too expensive or the therapist is not readily available when you want them to. And we recognize these challenges and we're trying to, whether it's increasing manpower, working towards broadening training for effective therapy, how do we make availability faster? But to answer your question, we are still not at a point where we can clinically say that now an AI-based chatbot is
Exactly.
good intervention.
Exactly.
So if any person who's seeking an AI bot for therapy, I would say it's important to also meet with a trained clinical professional who has 9 years of minimum training just to become a clinical psychologist, who can help better understand your issues and come to a more correct and appropriate diagnosis.
You're a third generation psychiatrist, right?
Yes.
What gives you the most hope when you treat addiction?
I would say the one thing that gives me hope is how I've seen people who improve and get better. So seeing things in that scale, it really keeps me pushing that this is the change that we want to bring for people.
I've seen your grandfather work till what, 98?
He practiced till 97.
97, yeah, I mean, and that attendant of his also cap. Wagmare, yes.
Yeah.
Yeah. I think he did practice till his last day, right?
Yeah.
Almost, yeah.
And I think, that's the beauty of clinical practice, that, you never retire.
And I was amazed to see, even at that old age, there were hordes of people still waiting to get a consult from him, That was a different aura of that man.
And I think we've now, as time passes by, we're seeing a different sphere and different aspect of how treatments have gotten better.
Obviously.
And I think we are building upon the legacy of our forefathers and fathers to, push the envelope further for improving clinical services.
Right. Anything else you want to add before I let you go?
Well, I think that's about it.
I hope you had fun.
Oh, very much. And I would say, we've covered everything. And for more questions, I think you and I can always have this sit down again.
Yeah, I mean, we can choose another topic and let's do a deep dive on that later on.
Oh.
We can surely do that. Thank you for being here.
Thank you.
Let's have some lunch.
Absolutely. I am famished.